Hello and welcome to Medtalks with Dr.moin. Today in our studio we have esteemed cardiothoracic surgeon Dr. Rajshekhar Rao. Dr. Rajshekhar Rao is a cardiothoracic surgeon. He is the head of the department cardiothoracic surgery and he has been working in care hospital since 2000. Sir, I know that you have been in care hospital since long time.
First of all, thank you, Dr. Moin, for inviting me to your Medtalks with Moin. I'm
Pleasure, sir.
following it up regularly, and it has been a great journey. I've been following all your interviews and everything.
Sir, there is a term called transplant. So, you know what I'm going to talk
Yeah,
to you about. Heart transplant. So heart transplant is something you bring somebody's heart into a patient who is need a heart. Like, is it really you will be putting somebody's heart into somebody's body? Is it really true?
Yeah, it is. You have touched a topic which is very close to my heart, actually. I'm very keen on doing
Heart
heart
transplants.
transplants and ventricular assist devices, actually. So, basically, here comes the area heart failure. So, end stage heart failure has got a very few limited options
Okay.
as treatment.
Okay.
So, all the heart diseases ultimately end up in heart failure.
Right.
So, when I say end stage heart disease means any heart problem ultimately end up in heart failure.
Okay.
If you see, there are 26 million heart failure patients in the world at this point of time,
Wow.
and 5% of them are in India. That is the burden of heart failure in India. So, heart failure is really a big problem. In our day-to-day routine, we see at least 3 to 5 patients with heart failure. As a surgeon, I see less number of them, but cardiologists, they see, in their practice, they see 50% of the heart failure patients.
They manage them medically.
Yeah. So, when it comes to the heart failure management part, with the optimal medical management, they will be able to improve their survival.
Okay.
But in spite of optimal medical therapy, if patients are still symptomatic, then comes the role of mechanical circulatory assist devices and heart transplants.
First, you
So,
try to put that device called LVAD, right, sir? That is
LVAD,
ventricular
yes,
assisted
yes,
device.
yes.
Okay. So what does it do, sir? You do something like you put a device into the heart.
Correct. So, let me put it this way.
Okay.
End stage heart failure, we have two options
Right.
to go for heart transplant. I would say that that is the best option,
Okay.
provided patient is fit enough to undergo heart transplant and the organ availability is not an issue. Because when we do heart transplants, we need to have a donor heart available.
That is the biggest challenge.
That is the biggest challenge we face.
Right.
The same compatible donor should be available.
Right.
And then they should be available before the patient deteriorates. Some people in the waiting list itself, they will deteriorate and they may succumb.
Right.
So, that is the issue.
Right.
So, when the patient requires heart transplant, when organ is not available, patient is deteriorating, that is when comes the option of mechanical circulatory assist devices,
Okay.
MCS.
Okay.
That is called left ventricular assist device or right ventricular assist device or biventricular assist devices.
Okay.
These devices are basically left ventricle, for example, like I said earlier, it is a muscular pump. So, it sucks blood and then pushes it to the body. So, in assist devices, what we do is we implant a miniature machine into the chamber. For example, left ventricular assist device means we provide this device to the left side of the heart.
Okay.
So, heart, like I said earlier, 2 chambers on the right side, 2 chambers on the left side.
Right.
The right side chambers, they push, they receive venous blood
Right.
and they push it to the lungs.
Lungs.
For oxygenation.
Right.
Whereas the left side chambers, they receive oxygenated blood, good blood from the lungs and they supply it to the entire body. For example, if left ventricle is failing,
Right.
if patient has got heart failure with a very much impaired left ventricle which is unable to function, especially when left ventricular ejection fraction is less than 20%.
Okay.
And patient is in intermax class 3 or 4. In those situations, if donor organ is not available for a heart transplant, then we have to go for what is called a left ventricular assist device. So this is, for example, we have got the latest HeartMed 3. Recently, we did HeartMed 3 left ventricular assist device.
Okay.
So the only problem with the device is that it is very expensive.
Okay.
This particular device costs you anywhere between 85 lakhs, device itself.
Oh my God.
And then the additional expenditure of surgery and other things.
So at the max, how much somebody would be ending up paying for that LVAD?
1.2 to 1.3 crores.
1.2 to 1.3. A normal person may not be able to
Make
afford it.
Afford
And
it.
how are the outcomes with that, sir?
They're very good.
Okay.
They're very good. See, the advantage of LVAD is that you don't need to give them immunosuppressant medications,
Right. Which you give in
which is in heart transplant.
patients.
Yeah,
Okay.
to prevent rejection. But you have to give anticoagulation because these are the metal parts. Titanium parts are there. They are inserted into the heart.
Right.
So, and then the blood is in continuous contact with this machine. So, you have to give anticoagulation, means blood thinners you have to give.
Right.
Maintain blood thinner level INR around 2.
Okay.
That is
So that
standard.
there are no clots.
No clots.
Right.
Because this HeartMed 3 machine is magnetically levitated. There are no bearings inside.
Okay.
It's only magnets are there. The magnets, they propel the blood flow.
From where do they take the energy, sir? Is there a battery?
No, there is a drive line is available. We bring out the drive line through the chest
Okay.
outside, and then that is connected to a battery.
Externally.
So, externally.
Okay.
So the battery is charged.
Okay.
The patients get around 8 batteries. Each battery lasts for about 24 hours. So in the night time, they can disconnect the battery. They connect it to a charger directly while sleeping.
Okay.
So it gets there's no need for battery in the night time. But with this, the outcomes are fantastic.
Okay.
LVAD improved the survival and quality of life for patients with chronic heart failure who are otherwise bedridden kind of a thing. So I myself, my patients, they are doing very well with LVADs.
Sir, you said like ejection fraction of less than 20% is the ideal, what do you call the range where people should go on to some assisting device.
Yes.
So now, after you put this LVAD, what would be the ejection fraction, sir? How much it may come to? Like, will it be like optimal, suboptimal?
Yes. See, the indications for LVADs, like I said, there are different indications. It's like a bridge to transplant.
Okay.
When donor organ is not available, you do an LVAD.
Right.
When organ is available, you remove the LVAD and do a heart transplant.
Okay.
And there is what is called a bridge to recovery. Okay. Means, for example, a young female postpartum cardiomyopathy. After delivery, she developed cardiomyopathy.
Right.
With ejection fraction of 20%. So in postpartum cardiomyopathy, there is a chance for the heart to recover. It's a matter of time. So by doing LVAD, we are giving heart that rest. When to recover. So we closely follow it up. If the heart recovers, if the ejection fraction improves, then we explant the LVAD.
Okay.
Suppose if left ventricle doesn't recover, then we do heart transplant. Whatever said and done.
You are saving her from landing onto a heart transplant candidate.
Yes, provided the myocardium recovers. Yes.
So this device is assisting her heart to recover. Once her heart recovers, you remove this device. In case you don't do that, she may become a candidate for a heart transplant, which becomes a bigger story.
There are people who don't want heart transplants.
Okay.
So in those situations, what we call it is destination therapy. So the LVAD as a destination therapy. That means they keep the LVAD and they will manage it for the rest of their life.
Okay.
So LVAD is basically used as bridge to transplantation, bridge to decision making, bridge to recovery, and as a destination therapy. Destination therapy means
permanent. On that permanently.
Yes.
It's an amazing thing, sir. Where are we coming from? From the iron age, the stone age, and now we are on LVAD. It's a beautiful thing to listen to and to understand. And if somebody requires some kind of problem, somebody has some kind of problem like sir has said, they can avail this beautiful device called LVAD. Sir, now transplantation. So as you said, like bridge to recovery. Somebody is a candidate for transplant, cardiac transplant. And in that mean process, you put him on LVAD.
LVAD, yes.
And whenever there is a heart available, you remove this and give him a heart.
Yes.
Right? So, sir, how do you do this heart transplant? Like, how do you decide like this patient is going to be a real donor?
Okay. There are different methods
Right.
by which we take donor heart.
So, the heart has to be healthy, first of all.
Heart has to be healthy, number
Right.
one. Number two is that it has to be from a donor who is younger than 55 years,
Okay.
not an older thing.
55.
And female heart to male heart, I really don't like.
Really?
Yes. Male to female heart is okay.
Male to female is okay, but female to male is not okay.
Not okay. But if there is no choice, I will use it. But in general, the outcomes are better for male heart to female rather than female heart to male heart.
Oh my God, and not to offend the females, but is female heart really going to cause trouble there?
It does. It does.
Okay.
It's because in general, the female hearts
and
are
the
size matters.
Of the pump of the ventricle,
yes,
right?
Yes, size of the ventricle and the body stature. If it's a male, usually are big built, and the females in general are a little.
Yeah, fragile and like they are like not as
as bulky
Herculean,
as
Hercules.
Yes. So, and it is well proven in our studies that female heart to male heart, the outcomes are not that great. When we have no choice, we use it. But then outcomes are not great.
Okay.
So, these are certain things we use. We compare the heart size in the chest X-ray, and then there should not be any infection. And the donor should be well maintained. Pressures with pressure agents, the blood pressure has to be maintained nicely.
You should not have any other valvular diseases, arterial diseases.
Yes.
All this. A healthy heart.
Healthy heart. If donor age is more than 40 years, then we prefer a coronary angiogram before taking up the heart.
And another important thing is, a donor, after donating, he should not eat that heart. It means that he is coming to a stage where he is not going to be alive.
Yeah.
So that is the stage.
That is the stage.
So how do you choose that person?
No, it's a difficultly brain dead patients
Right.
are there. Patients who succumbed to road traffic accidents,
Right.
and they have massive head injury, and they are brain dead. Two neurologists usually declare if a patient are brain dead or not. Two neurologists, they independently examine, and then they do EEGs
Right.
to make sure that there is no electrical activity in the brain. Sometimes, if required, they may do cerebral angiography also.
Okay.
If in brain dead patients, there won't be much blood flow to the brain because it won't be consuming any blood flow,
Right.
any blood. So these are all and the apnea test they do. They do apnea test to make sure that the patient is brain dead. Then they counsel the family, the transplant coordinators, and the neurologists. They counsel the family, and then the family agrees to donate the organs. Then we have a good system called Jivandan.
Right.
And all recipients, they are listed.
Okay.
And whenever there is a brain dead donor is available, they will be elected, and they will allocate where to go, which organ from a particular hospital, where to go based on the priorities in the listing process. So we have got a very nice system.
Right.
The Jivandan has streamlined everything, transplant things.
So unlike people donating kidneys, this person who is donating a heart doesn't know that he is going to donate his heart.
It's
He
a
won't be able to make a
patients.
decision.
Yeah.
So anybody would like to do some miracle to the society or to this world should just decide beforehand and should enroll into the system, because after we all leave this world, I just believe that we all go to heaven. So heavens don't need our organs. So you can just leave your organs here for those who are needy and for those who are in real need of your organs. So I just request all of my viewers and my friends, just think about it to give a think. So
Yeah,
here
definitely.
a patient, we were talking about a donor, not about a recipient. We'll come to recipient shortly, but we are talking about donors. A person who is really thinking about saving somebody, you need not be a superhero. By just having a thought, a small thought of saving somebody, you automatically become a superhero. So so now they decide like, okay, fine, like that this guy is not going to survive. So there is no point, what you call supporting him, or there is no other way for him.
Yeah,
So that is the time where the physicians and the surgeons decide that his heart can be harvested. Now, what about the recipient?
Yes. Whenever we get alert that the donor heart is available, then we call the recipient. We recipients are already enlisted,
Right.
so they are all well prepared. So we call them into the hospital, and then we prepare them for a open heart surgery, basically. And we have to implant the heart within 4 hours.
4 hours from the time you have harvested.
Harvested, yes.
Right.
That is called cold ischemia time.
Okay.
Okay. So if your implantation time goes beyond 4 hours, then the outcomes are not that great.
Okay.
So there are a lot of other systems that are available. For example, there are assisted systems are available who perfuse the heart.
Okay.
Boxer systems are available, which are very expensive, which are not available in India at this point of time. But if you have to have a donor from a different city and the transport is an issue, then they can harvest and they can perfuse the heart in the box, and then you can get the heart and transplant.
Okay.
Okay, that option is also available, but at this point of time in India, those systems are not available. But we have to make sure that the time shouldn't be more than 4 hours.
Okay.
So accordingly, we time it. Once we start the donor heart harvesting, then simultaneously recipient operation starts.
Okay.
Okay. Once we receive the donor heart into the theater, and we must run.
Basically,
We have to run with clock, and then we have to finish it off as quickly as possible.
So it means that the recipients are already on the waiting list. They are already in the waiting list.
and fully
some
prepared.
candidate is available who is ready to donate. Unfortunately, his family has to take a decision that we cannot save our loved one, but we can save the other patient who is on the deathbed, maybe somewhere in the city or outside the city.
Correct.
So probably this Jivandan system, sir was talking about, beautiful system where they are like coordinating, because you don't know where is the heart and the heart doesn't know where is the recipient. Like the way they are coordinating and matching the time, and within that 4 hours of time, you have to harvest.
Yes,
and
harvest
bring in.
and bring it and implant it. And heart transplant surgery is like any open heart surgery.
Okay.
It's not that difficult, basically. Most important thing is selection of the recipients, selection of the donor, and management of the patient after heart transplant.
Okay.
For example, I have a patient by name Mrs. Adilakshmi. She has been seeing a care hospital Nampalli for the last 22 years.
Wow. You operated her 22 years back?
No. She had a coronary artery disease.
Okay.
She was stented.
Right.
Then she had a LV dysfunction. Then she was given ICD.
Okay.
And then she was managed. Finally, she managed somehow for the last 15 years. Now, in 2016 end, she came with gross heart failure. So now all options are exhausted. Closed. The only option left for her was to have a heart transplant. And they were very humble background. They don't have much resources available. So with all our help and hospital's help, we could perform her heart transplant in 2017. Okay. So it's 3.5, 4 years now. And she's doing very well. She's doing very well. Like I have got a couple of other patients who are also doing fantastic. So the post-heart transplant management of immunosuppression is a big task. So we need to have the heart transplant surgeon and then the heart failure cardiologist and transplant cardiologist should work hand in hand as a team to manage this patient to get the best outcomes.
Okay.
So that's very important, especially they are immunocompromised. Now we all know that we are in pandemic.
Right.
So pandemic affects people who are immunocompromised.
Right.
So it's a big task to manage these patients. Fortunately, 2 of my heart transplant patients, they got COVID, but then they recovered.
Okay.
So
Because of this immunosuppressive management and
now we had to,
Balance
meddle
them?
with the balance the medications and then, so with God's grace and with
great thing,
management,
sir. It's a great thing.
they recovered well because we were all worried about them.
Because it's a hard work, getting a heart and doing the job, and after that, it becomes another task to save them.
Yeah.
I just, I'm sure like it must be an amazing experience for you doing these beautiful surgeries and heart transplant per se. The word itself, it's something big to hear.
Yeah.
And the heart is the main part of the body which pumps, the vital part which pumps, your blood to the body. Sir, how many heart transplants so far you have done, and how is it, sir? What do you say? Like it's an easy task for you or it's a Herculean task?
I have done total 20 heart transplants,
Okay.
10 abroad, 10 in India,
Okay.
after which 16 patients are surviving at this point of time.
Fantastic. Okay.
So I did my first heart transplant in Sydney,
Okay.
that is in 2006.
Okay.
So it has been 16 years.
Okay.
Mr. Smith is surviving,
Wow.
is doing well.
Fantastic.
Doing
sir.
well.
Fantastic.
3 patients succumbed in Australia. 2 patients in the pandemic.
Okay.
2
Due to COVID, sir?
due to COVID.
Due to COVID.
Two
So no
patients.
mechanical problems, no other infections other than this
Yes.
COVID. So I would give a big round of applause along with you guys, sir. Amazing thing.
Thank you.
And
Thank
it's
you.
an amazing thing. Really, it's a big honor to have you here by our side in our studio. Thank you so much for talking to our viewers about your experience in cardiothoracic surgery.
Thank you, Dr. Moin.
Welcome to Medtalks with Dr. Moin.